Hello, everybody. Hope you're doing well and staying safe. Welcome to episode 7 of the Apollo Educational Series. My name is Arash Tagvai. I'm one of the medical graduates and patient care specialists that work at the Apollo Clinics. Today's subject is a very important one: multiple sclerosis. We're going to be going over all of the pathophysiology of the disease, and then we're going to tie into medical cannabis and how it can potentially help these people. If you are new to the series, welcome. I urge you to stay tuned in. We'll go over the finer details of medical cannabis later on, as mentioned, but initially I'm going to start off and dive into all things related to MS. If you are returning and a regular follower, thank you for your continued support. I'm going to get right into it, guys. This is a very complex subject. Let me just share my screen. Okay, guys. So, as mentioned, multiple sclerosis. First, we have to define the condition. Multiple sclerosis is an autoimmune disease, which means that the immune system is triggered to attack the central nervous system. The central nervous system is made up of the brain and the spinal cord. Everything else in the nervous system is considered the PNS, the peripheral nervous system. Okay? The variability of the symptomatology in multiple sclerosis is due to the involvement of the central nervous system. Anytime you have a disease where the central nervous system is involved, it's complex, but then you add an added layer of complexity with the autoimmune disorder and the immune system's involvement, and again, it becomes very difficult to predict. It becomes even more difficult to treat, and again, this is where we can potentially play a role with medical cannabis. But let's get a little more finer with our details here. Multiple sclerosis is an attack of the central nervous system, more specifically, a protein known as the myelin sheath, or myelin. If we pretend my arm is a nerve and it is completely covered with myelin, the myelin's main job is to allow stimulus to travel from one side to the other very quickly. That is what allows us to move our hands away when we feel something that's warm or if we feel pain, right? It's a very, very fast reaction. If you actually think about it, the human body is incredibly fast, and that signal travels very quickly in our bodies. Now, myelin, if it's not present, it'll take the stimulus from going from one side to the other, and it can potentially slow it down and even sometimes stop, so the signal is never received. And again, that can lead to a wide variety of symptoms that can progress or stay or remit as well. And again, I'm going to go over that. I'm using terms that are used to break down the different types of MS, but I want to make it very clear that we understand what is being affected in multiple sclerosis. It is the myelin sheath that covers the nerves in our central nervous system. Because it is an autoimmune condition, it falls under one of the 4 types of hypersensitivities. To make it a little bit simpler to understand, the 4 types of hypersensitivities are just simply ways of saying an immune reaction. Sometimes people will have a hypersensitivity or an immune reaction to pollen, right? And in spring and summer, or even in fall, when certain plants are blooming and there's a lot of pollen in the air and they inhale some of that, they can have congestion. It can cause them to sneeze or cough or have a runny nose. Again, that's called hay fever, right? But that is an autoimmune response to the antigen known as pollen. Other people will have different types of hypersensitivity reactions to certain things. For example, a bee sting can cause full body anaphylaxis, which means, again, the immune system is now fully turned on to an antigen known as the venom from that bee sting, and it's causing all of these symptoms in our body. And when it becomes dangerous is when the throat is involved, right, or anything in the breathing of a patient, and it becomes very, very dangerous. So if someone gets stung by a bee and they start swelling in the arm, you better move quickly, because if that swelling gets to the neck or the head or the throat, then that person may have trouble breathing. Another very common anaphylactic reaction is shellfish. That's another one that you see. A person goes to a seafood restaurant and they're eating, and all of a sudden, and it's very quick, and all of a sudden they can't breathe. And everybody thinks that they're choking on seafood, but in reality, they're going through anaphylactic shock. You must use an EpiPen, but the treatment is not over. After an EpiPen is administered, they need to go to the nearest emergency room for at least 24 hours of monitoring to make sure the immune system is calmed back down. Right? The situation is very serious. So, coming back to multiple sclerosis, it is a type 2 hypersensitivity. A few other conditions that fall into type 2 hypersensitivity would be myasthenia gravis, which is another neurological musculoskeletal disorder, right? And then the third one would be pernicious anemia, which is another interesting example of how the immune system can can really take out a cell type and cause problems down the line. With pernicious anemia, the immune system attacks a specific cell called the parietal cell in the stomach. The parietal cell is responsible for creating intrinsic factor, which helps us absorb B12. So if you're following, we destroy the parietal cell with the immune system. We don't have the ability to create intrinsic factor. We lose the ability to absorb B12, and that shows when red blood cells are unable to replicate. So an anemia is involved 4 steps down the line. Again, that's another type 2 hypersensitivity. If you've been following along with our series, I've also discussed in previous topics the difference between osteoarthritis and rheumatoid arthritis. I said at the time in that video that rheumatoid arthritis was an autoimmune condition. It falls under a type 3 hypersensitivity. So again, just things to keep us in the loop and to keep us sharp. Another popular type 3 hypersensitivity is lupus, another popular condition. So keeping all that in mind, coming back to MS, because it is a type 2 hypersensitivity, we are unsure of the cause, which means that it is idiopathic. There is some association to genetics and environmental factors, but again, I'm going to get into that later in the presentation. Before I leave this slide, I want to go over the 4 different types of MS. Initially, there is the clinically isolated syndrome. This is a person who presents with a loss of function or pain or some sort of mood change. It can affect any part of the body, again, because the central nervous system is connected to every single part of our body. It can affect any part of our body. Generally speaking, clinically isolated syndrome is the beginning of MS for most people. Very few only have that one syndrome and never have any other symptoms. It can occur, so there is a condition called clinically isolated syndrome, but most times it does go into relapsing remitting. Relapsing remitting, what is that? It's kind of self-explanatory. The condition can have a relapse and the immune system turns on and it attacks one area of the central nervous system. And again, I'm just going to choose an example as my arm because it's the closest and easiest. If I have something in the central nervous system that is an area of the central nervous system that is attacked by the immune system and it causes decreased myelin in the nerve endings that leave my spinal cord and go to my arm, I may lose function in that arm. I may not be able to do things as quickly. I may lose muscle tone and I may lose complete function. Those symptoms may present and remain. They may present and then lessen in severity. They may present and disappear altogether. Again, it remains very unpredictable when it comes to MS. The one after relapsing remitting is secondary progressive. Secondary progressive is a lot more aggressive and it moves quicker on the scale of loss of function. What do I mean by the scale of loss of function, guys? With any kind of patient's functioning, we start at the very, very top. They're highly functioning, and then something occurs and they lose a specific function, but then they continue on as normal, right? They're considered to be in remitting phase. And then again, potentially they could regain function, but if they have another relapse, then they go back down and then they lose a little bit more function. That's relapsing remitting. With secondary progressive, unfortunately, with their function starting here, it's a much faster stairwelling down. And then we have primary progressive, which unfortunately, the slope is just, it's a straight line. So these patients, it's very unfortunate. They are diagnosed and they decompensate very quickly. Multiple sclerosis is named after the imaging that was found on the initial diagnosis of this condition. So I'm going to get into that before as I change the slide here. So these are some of the symptoms that can present with MS. As mentioned, because the central nervous system is involved, it is very difficult to predict where these symptoms will present. But again, these are things that have been recorded with multiple sclerosis. And again, this is a worldwide condition that is being studied and looked at very, very carefully right now. And they want to find what the cure will be or what the causes will be so we can potentially protect future generations and then have a better angle to treat the condition. But let's go over some of these systems and talk about the potential dangers that a patient with MS faces. First and foremost, right at the top left, you can see vision, okay? A visual disturbance is not pathognomonic, but it is a very common presentation of MS. This should alert any physician right away. Wait a minute, unilateral optic neuritis, which is visual disturbances in just one eye, should turn on the physician's mind to a potential of MS. Keeping in mind that our eyes only have one nerve, the optic nerve. If the immune system attacks the myelin in the optic nerve, then there can be unilateral vision loss, there can be a tunneling, there can be a curtain-like loss. Again, there's a lot of different presentations to the vision loss, and like mentioned, sometimes this can be permanent, sometimes this can return in function, and sometimes it can go completely back to normal. Again, it's hard to predict. The spinal cord is probably the area in which the autoimmune attack is going to cause the most problems with spasticity. That is when the patient loses their ability to either relax or contract a certain area of their body. Now, again, I'm just going to use my arm because it's the easiest example. But if I want to reach over and grab the water bottle that's sitting on my table, I have to initially make that decision. I have to make a relaxing move, a fluid move to reach out, and then I must contract and pull that water bottle back to my face. If anywhere along the line I have lost function, if I'm unable to relax, I'm just stuck in a constant contraction, well then guess what? That's considered a spastic limb, and that's something that does occur in MS. The opposite can also be true. If the arm is very relaxed, and I can relax and I can kind of get my arm there, but I'm unable to contract, well then that's when you have a patient that's reporting, I just can't hold on to my coffee cup, or I continue to drop things unbeknownst to me. I don't feel it falling, but it falls and I hear it hit the ground. So again, this is something that occurs and it can present with as an initial symptom or later on with any type of MS. There is numbness involved, there's neuropathic pain involved. If the area of the central nervous system that is attacked by the immune system is closer to the frontal lobes, there will be mood disorders. Okay, keeping in mind, the frontal lobe is one of the main areas that makes up our personalities, that makes up who we are. If that is attacked, then all of a sudden you have someone who is completely different in character. And again, it's a very debilitating condition for not just the patient, but for their families. It's very disturbing. When it comes to the actual risk to life of MS, it's very important to discuss the urinary symptoms or the urinary system. The symptoms of MS, again, can cause numbness or can cause a lack of communication between one system and the central nervous system. Our bladders work on stretch receptors, right? That's what gives you the feeling, oh, wait a minute, I gotta go, right? I have a full bladder and that is stretching and it gives my central nervous system a signal, you better find a bathroom quick because we're filling up. Now, if along the way that communication is broken, a patient will not feel that they are filling. And unfortunately, once those stretch receptors get to a certain maximum, the patient will evacuate. And again, they are not aware that they had to go to the bathroom and they feel nothing. And they will unfortunately evacuate their entire bladder. And this can cause problems, not only for just how they feel and what they can do in terms of functioning, but one of the main areas of infection is the genitourinary tract. So if a patient is unaware that their bladder is full and the stretch receptors reach their maximum and they evacuate while they were asleep and they spend several hours there and then they wake up and they realize, oh my goodness, I am wet, and a urinary tract infection starts, and that infection is unbeknownst to the patient and it turns into an ascending infection, which means it goes from the bladder up to the kidneys. It now has far more blood supply, it has new proteins to digest, it can graduate into sepsis. And again, that's very dangerous for MS patients. Sepsis will put any patient into the hospital. You now have the risk of multi-organ failure, which is ultimately what these patients suffer from. This is very, again, it's very unfortunate, and it's very debilitating to these people and their families. So the bladder is not to be missed when talking about MS, because again, it is the cause of that. Another area that is very important to discuss when it comes to MS is mouth and speech, okay? If any patient experiences difficulty with breathing or swallowing, again, the incidence of infection will go up, and this causes more complications for the patient. If I can't fully swallow my food, and again, this happens to most people, MS or not, sometimes when we take a breath and we're in a conversation while we were eating, we'll inhale, and the common phrase is, it went down the wrong way. Well, that's because the food went down the larynx where air should go, no food should go. But if that occurs with MS, the problem is they're at a high risk for what is called aspiration pneumonia. And again, that is something that will put them at risk for systemic infection and sepsis. Of course, The breathing mechanism is very important to protect these patients as well. If they lose the ability to fully inhale and exhale, or their diaphragm loses innervation to the central nervous system, then it becomes difficult for them to inhale and exhale. And now we have to put them on a ventilator. And a ventilator, again, increases the incidence of all respiratory infection, which can graduate into sepsis, multi-organ involvement. And that's where the danger is with MS. I have not yet discussed the loss of function when it comes to the lower limb or upper limb. Sometimes the immune system will take out the central fibers in the brain, and that is where our coordination for our lower limbs exists. So overnight, a patient will awake and realize, oh my goodness, I can't really move my legs, and now unfortunately they're in a wheelchair. We do not know if that will remit, and if they will be able to stand and walk again, or if that will last, or if that will get worse and progress, and they may lose complete functioning of their legs. Again, it really is unpredictable and hard for us to know. So another thing that's important to recognize is the method in which MS is diagnosed. Okay, I mentioned earlier in the presentation that multiple sclerosis is also leading on to the imaging findings that are found with this condition. The gold standard for any diagnosis in MS is an MRI. Okay, that image will show a lesion that has been sclerosed by the immune system. What does that mean? That means that that area where the myelin has been digested and eaten up will be a little bit stiffer and slightly more rigid than the rest of the tissue around it, and that'll light up in an MRI. So initially, when they found this condition, there were multiple sclerosis lesions. And they always are separated in time and space. What that means is separation in age. It looks like this lesion has been present for nearly 2 years, whereas this lesion is, a lot younger or a lot newer to the central nervous system. So these are the newer presenting symptoms, and this is what the patient has always had. These are multiple sclerosing lesions. And that is why they named the condition multiple sclerosis. After an MRI, a physician may choose to do what is called an EP test. Okay, that's an invoked potential. The fancy way of describing the movement of an impulse or stimulus is calling it an action potential. Okay, so the action potential of a nerve is very high, but obviously with myelin being taken out of the equation, it can be very slow or it can fail to arrive altogether, and a physician can measure that. They will put a whole bunch of electrodes, and again, I'm just using my arm because it's the easiest example. They will have a bunch of electrodes and send a small shock from one side of the nerve to the other, and they will measure how fast it makes it there. And they can again tell if the myelin sheath has been damaged or compromised in any way. The final way a physician may choose to diagnose a patient with MS is a lumbar puncture. Okay? This is a very small needle that will go into the small of the back, lower back, the lumbar portion of the spine, and they will pull out what is called CSF, cerebral spinal fluid. This is a special fluid that our body produces. It's very similar in composition to blood, but its job is to protect from impact the central nervous system. And of course, it does provide a lot of electrolytes for the nerves as well. So a physician will pull a small sample of that out, and what they are testing for are the antibodies from the immune system towards the central nervous system, anti-myelin antibodies. Since they've made that discovery, a lot of therapies have come out to target that cell that is creating that antibody that is attacking the system. So again, just as we continue to learn more about MS, we continue to understand how it occurs and how to treat it. We are far from complete. The condition is still considered an idiopathic, chronic condition, because we can only really hope to control the relapses and help to control the progression, but there is no cure for MS right now, which is, again, an unfortunate fact that we are hoping we can continue to progress towards. Very important. So we've talked about the diagnosis, and then we can now talk about how medical cannabis can potentially help with these patients. CBD. Now, this is a very popular chemical compound that comes off of the cannabis plant. Okay, it's called cannabidiol. It has receptors all over our body, and it can play a role in helping with pain It can also work as an anti-inflammatory, and we dare say it has immune modulating properties as well. Guys, the third point that I've made here, the immune modulation, there is no long-term research for CBD and immune modulation, but from what we gather in clinic and what we see from our patients and what we hear back from our patients, it always is a bit of a surprise to them and their neurologist, right? We'll hear from neurologists and patients saying, well, I used to have 2 or 3 attacks a year, and now it's slowed down a little bit. And again, I'm getting 1 a year, I'm sleeping better, the pain is decreased. So to me, this feels like it's helping with the relapsing of, or the flares of the immune system as well. Again, the long-term research is not there, but it may be presented in future. We're optimistic. It also may be presented that whether they use cannabis-based medications or not, ultimately 25 to 30 years is still when an MS patient is facing catastrophic problems, and that might still be the case, but they're saying that the symptomatology is far better controlled with the use of medical cannabis. Again, that's just a potential prediction from me that could occur. CBD is the main chemical component that we use in clinic to address multiple sclerosis, and then later on, we may introduce THC. THC is the second chemical component that is used from the cannabis plant. The difference between CBD and THC is its affinity. THC binds at a much higher rate to the same receptors in the endocannabinoid system than CBD does. The only disadvantage to THC is that if we use too much of it, it can saturate in the central nervous system and cause the feelings of being unwell, the recreational side of the recreational side of cannabis. We stay away from that. Our goal with the use of THC is to attain a good sleep cycle, to help with neuropathic pain, and to further help with inflammation. Keeping in mind with MS, after these attacks occur on the myelin sheath, it's not like the immune system says, well, my job here is done, and they pack up and leave. There's a lot of inflammation that is left behind when an immune system is flaring. The key word for inflammation is permeability, okay? That is what swelling is. This is an evolutionary reaction by our bodies to help with cell flow. If I have an area of the body that is hurt, either physically hurt or infected, it's good for that area to swell because that allows more immune cells to come and go. Unfortunately, that same swelling and increase in permeability, allowing more cells to arrive, can put pressure on everyone around it. And that's what causes the neuropathic pain with multiple sclerosis. There is musculoskeletal pain also felt with MS. We can't rule that portion out, but the neuropathic pain is what we hear a lot about in clinic and what we hear a lot of positive results with the use of cannabis-based medications for. Keeping in mind that THC and CBD have very similar actions when it comes to pain control, we have to remember that it's about finding the right balance for the patient. There is no such thing as a one-size-fits-all when it comes to medical cannabis, which is why it is so unequivocally important to have a physician involved when it comes to your care. Especially if you have a family doctor, a neurologist who are following your condition. The more minds involved, the better. Apollo will have a physician follow you for medical cannabis, and then the 3 doctors will communicate via their own consultations. They will say, well, patient so-and-so is doing this now, and patient so-and-so is doing that. Or the neurologist will send a note and say, patient Mrs. Smith is doing a lot better in the last 6 months since she has initiated medical cannabis. Can you enlighten me to what she is using so I can potentially use less other medications for her symptomatology control? Again, guys, that's just an insight onto what we hear in clinic and our day-to-day progression with our MS patients. This is a further breakdown of the endocannabinoid system, I had mentioned to you that there are receptors everywhere in the body, and this is, again, just a better understanding of them. The brain, the central nervous system, has both CB1 and CB2 receptors. The common thinking is if you use THC, it affects the brain. If you use CBD, you're okay. And you're not affecting the brain. Guys, you're okay using either, okay? It's just about the dosage. The correct dosage of THC will not allow people to feel unwell, but they will attain all of the medical benefits. Again, the unequivocal importance of a physician being involved in the medical cannabis journey, it can't be stated enough during this video. Sometimes CBD is enough to help patients with MS. Other times they will come back and say the CBD is helping, but I would like to say something more at night. At nighttime is when I have my neuropathic pain in my legs and my back is really bad. So, a 2.5 milligram or a 5 milligram of THC is helping me sleep, is helping with the pain, and increasing my overall quality of life. Again, this is where the THC and CBD chemical compounds can play a role in our body, guys. I've added a slide here for where the exact mechanisms of THC and CBD play a role. And if we look here, right, this is the pre and post-synaptic cleft in the neurological system. It's important to remember there are CB1 receptors here. And again, these nerves are found everywhere in our body. And the THC, nabilone, and other synthetic compounds that are made to mimic the compounds of medical cannabis are activated right there in the cell. And if we pay a little more attention to exactly what's going on, it plays a role in potassium levels, it plays a role in calcium levels, and calcium and potassium also ultimately decide what kind of vesicles are released into the presynaptic cleft area, which is the communication between the nerves. So if a nerve has neuropathic pain and it keeps saying, I'm in pain, I'm in pain, I'm in pain, I'm in pain, well, that goes into the central nervous system and the patient is left just in agony and the feeling of this pain. Now, if I'm able to control the frequency of this, and it goes from, giving 100 signals a minute to giving 20 or 30, well, the patient says, I feel a lot more relief. I can relax that leg now. I can get at least 5 hours of sleep tonight. That's something that hasn't occurred in years. Again, that's to us a massive victory in the quality of life of that patient. Our bodies also create 2-AG and anandamide. This is an important point because they are a part of the endocannabinoid system. Our system is already in place, guys. We are tapping into it with THC and CBD and helping normalize those levels. Other potential therapeutic benefits, I've spoken a lot about MS and how we can help, but again, other potential therapeutic benefits of medical cannabis are on this list. If we look, there are a few that are related to MS and there are a few that are not. First and foremost, neuropathic pain. I've discussed with you guys how that occurs and the permeability that the immune system causes, right? We have migraines as a type of headache that occur. Migraines can be associated with MS, but there are a whole bunch of different types of headaches that come with MS, not just migraines. It is impossible for a patient to receive a long-term chronic diagnosis and it not affect their mental health. Anxiety, stress, depression, and a sleep disturbance are some of the main complaints of MS patients. We know that CBD plays an important role when it comes to the treatment of anxiety. It can also help with depression, and sleep is one of our favorite things to help patients with. We have patients come back to us and say, well, I used to take this medication and I used to wake up feeling very groggy. Or I used to take this medication and it never helped me sleep. So now I have a set medication with medical cannabis, and there are nights where I don't sleep as well as I want, but generally speaking, over a course of 30 days, 20 of those days I'm sleeping much, much better than I was before. Again, that's considered an adjustment for the quality of life of that patient. So again, just coming back to multiple sclerosis, we look to have help with the pain and the sleep that these patients are experiencing, or the sleep disturbance that they're experiencing with MS. Spasticity, I've explained how it is difficult for them to relax and contract, or they've lost the balance due to the lesions from MS for relaxation for fluid movement and contraction for functionality. So again, if they've lost that simple dance between relaxation and contraction, it becomes very difficult for them. I just wanted to take a few moments to go over the Apollo process, right? Keeping in mind that we are open and considered an essential service, and we see patients from coast to coast. Initially, any patient who comes to Apollo will receive a triage. This is where we will capture the information as to what they are looking to use medical cannabis for. If a patient says during their triage process that they are suffering from MS and that they heard from other friends in a group that they had had success with the use of medical cannabis, well, guess what? I'll probably want to have more information from that patient. I'll say, can I attain any reports from your family doctor? Can I attain the diagnosis criteria from your neurologist? Because I want to gather all that information so I have it for our physician when we discuss medical cannabis, right? Great thing for us to know. The consultation is your visit with the healthcare professional. Then a medical document is generated. That is your prescription. The prescription is followed by a full education and a registration with a licensed producer. And then the medication is sent directly to your door. It's contactless. It's been that way before the pandemic, and it continues to be that way now. Okay, guys, so that brings me to the conclusion of the presentation, and I'm going to go over a couple of questions that were sent in. A few of the questions that came to us, I covered in the presentation. A lot of people were asking what the symptomatology of MS could be, or how it can progress or not progress. So hopefully I've covered those questions for you guys. One of the questions that I really liked that came to us that I didn't cover in the subject that I'm going to cover, or in the presentation that I'm going to cover now, is what is the standard treatment for MS? That is a very big question, and I'm going to cover it at a very high level, guys. There's a class of medications called the DMTs, the disease-modifying therapies, okay? This is the medication that is administered orally, injectably, by a neurologist who is following the condition of MS only, okay? They realize that this patient is in a flare, in an acute flare setting. They want to give prednisone, okay, to control the acute flares. And long-term, they can do monoclonal antibody injections, which are antibodies against the antibodies that your body is creating, okay? I know it's complex, but we have to pay attention. We're attacking the guys that are attacking us. And again, these are new design therapies that show pretty good results. And again, they're able to control the progression of the disease quite well. Unfortunately, it isn't closing the door on the condition. It still is a chronic active condition that can relapse at any time. Other than that, we have control of symptomatology. Once we have left the disease-modifying therapies, we have control of symptomatology. This is where we believe that cannabis-based medications play a very important role. Unfortunately, the family doctors or the neurologists that are treating this area of the condition are left with very few options. Opioids are where they would initially go. Now, I'm not going to spend time on the opioid crisis and the things that can go incorrectly for patients when using opioids. And I don't mean to throw shadow at modern medicine. Trust me, those medications have a place. Unfortunately, they were being overused for a long period of time, and now we are more aware of it. In fact, we're kind of hyper aware of the problems that opioids can cause, ignoring the positive effects they still have for some patients. They are, when used correctly, an excellent tool in a physician's belt. But for the time being, we want to exhaust all options for the treatment of symptomatology. And again, cannabis-based medications can help with neuropathic pain. They can help with musculoskeletal pain. They can help with the sleep issues that arise and the overall mood that can be attacked and changed and adjusted with MS. So that was a very good question that I wanted to address. Remember, disease-modifying therapies, we want to be a part of that. We're hoping we'll be a part of that. We hear from our patients that we're a part of it, but the symptomatology control is where most of our focus is and where we have good evidence-based medication that we are helping these people deal with their pain. So really good question, and thank you for sending that in, guys. The next question I wanted to go over is mentioning here, what is the cause of MS? Okay, and again, I mentioned briefly earlier in the presentation that it is called idiopathic, which is just a fancy way of saying we don't know. There is a small genetic association. About 25% of patients with MS have been found to have a small mutation in an area of their genetics. But again, 25% is not enough for us to say, yes, this is it. Yes, this is the cause. Yes, let's prevent it and add genetic testing to these people. But unfortunately, we don't have enough concrete evidence for that. There is also a lot of association with environmental factors. Smoking, primary and secondhand smoking, does increase the incidence of MS. Also, we have found that MS has a demographic in location to it. The further you are away from the equator, cold air climate countries have an increased incidence of MS as well. That includes Canada. We are among the top 5 in the world for MS diagnosis and incidence per capita. It's very high in Canada, unfortunately. Again, it has to do with cold air climate countries. So the cause is still unknown, but we know there's a slight environmental, a slight genetic, and then a slight behavioral involvement when it comes to the the statistics for smoking. But really, guys, smoking takes your chances of almost all conditions up. So I'm not surprised. All right, guys, that brings us to the conclusion of this week's episode. I want to thank you guys so much for sending in all of the questions and all of the ideas for future presentations. We're going to take them all into consideration. Stay tuned and stay in touch. And thanks again for your support. All of the best. And I hope you continue to stay safe and enjoy this beautiful summer we're having.